Thank you very much for this kind introduction, and thank you for inviting me here today. I'd like to thank Dr. Nagla Shokri for inviting me. It's an honor and a pleasure indeed to be here. So my first slide will be just my disclosure, and then I'm going to give an overview about the burden of disease in most of the resource-limited countries, and I'll focus a little bit on the Egyptian program and our national experience, access to care and treatment, and the challenges and future perspectives. As we all know that the global health challenge of HCV is tremendous. At least 150 million people are infected globally, and most of those people are coming from the resource-limited countries. And as we can see here, Egypt in the middle with a big bubble where the burden of disease is quite high. Egypt is considered by the World Bank to be a resource-limited country and is considered to be a lower middle-income country. And most of those lower middle-income countries, as you can see here, are responsible for more than 80% of the infections that are ongoing globally with hepatitis C. Not only for the adult population, but also for the pediatric population that's completely ignored in all the studies and in all clinical trials. Most of those infected below the age of 15 are coming from middle to low income countries. And as you can see here that more than 85% of the infections are coming from sub-Saharan Africa, Southeast Asia, and the northern part of Africa, including Egypt. The highest country actually having the burden of disease for pediatrics is Nigeria because of HIV co-infection, and which facilitates perinatal transmission. And Egypt has almost a 0.5% infection rate in children. So what about the genotyping? The genotypes, the distribution by GDP is shown in this map. And as we can see here, Egypt has genotype 4 as the most prevalent genotype. And genotype 4 has not become rare as we previously thought, but it at least forms 20 to 25% of the global genotypes of hepatitis C. So more and more clinical trials are being conducted for genotype 4. Most of the low middle income countries, and in this table, we can see here most of the African countries have genotype 4 as a major prevailing genotype. This is a systematic review of the HCV prevalence in sub-Saharan Africa, and as we can see, it has 213 studies from 33 countries, and the pooled prevalence of all cohorts was around 2.98%. From the 185 low-risk cohorts, 3.04% in antenatal clinic groups, and for other general cohorts, 6.9%. While the pooled prevalence across all the high-risk groups was 11.8% and 9.95% in liver disease patients, with 5.7% in those co-infected with HIV. So the burden is quite high in sub-Saharan Africa, and it's important that we focus also on countries that are low and middle income so we can eliminate the hepatitis C globally. So in Egypt, the National Committee for Control of Viral Hepatitis was established in late 2006. Before that date, we didn't have a program. The government was not treating a single patient, and there was no program in Egypt, despite the fact that we knew that we had a very high burden of disease. And our main targets were, first of all, to integrate hepatitis C within the demographic health survey to identify the burden of disease in 2008. The last survey was in 1996. Development of a national strategy, establishment of a treatment program, and the government actually was advocating for treatment of all patients with hepatitis C at that time because there was huge demand from the public and from the patients and indeed from the media. Clinical research as well as management of advanced liver disease, and we managed to integrate HCV testing for the first time within the demographic health survey. We published the first national strategy in 2008. We had a limited university campaign for awareness, vaccinating 30,000 students against hepatitis B. However, the other prevention activities remained fragmented, like infection control, and research continued with management of advanced liver disease. This is a snapshot of our program from 2006 through 2014. This is on the top left part. As we can see, this is the national survey done at that time. And as we can see that the prevalence rate, the overall viremia was 9.8%. For those above the age of 50, it was 25%. We published the first Egyptian strategy for control of viral hepatitis. And on the right side, we can see the awareness campaign where we had one of the young actors who was the face of the campaign at that time. On the top bottom part, we can see the liver centers that we've established in different governorates all over Egypt with trained physicians treating 350,000 patients with PEG interferon and ribavirin in the first 7 years. And we had a database networking system connecting all liver centers together with the patient's data. But we still had an incidence of 165,000 new infections on a yearly basis, mostly coming from medical care. Unfortunately, medical injections, intravenous infusions, stitches, surgeries, dental care, obstetrics, and a limited intrafamilial transmission to around 10%, mostly sibling to sibling, mother to infant, and father to infant at the lowest level. We didn't know much about the persons who are injecting drugs. This is a stigmatized and ignored population, as well as the incarcerated population in Egypt. In the study on the right side, we can see that this study was published in 2014. It shows that people receiving multiple injections, not persons who are injecting drugs, but people who like to take injections as their medications instead of the tablets or capsules, are the ones likely to transmit the infections more than others. And they transmit the infections to at least 3 to 4 people during their lifetime. So those are transmitters of disease, and those should be targeted when we think about prioritization of treatment. So the modes of transmission, as we can see here in Egypt, comparing to the United States, for example, it's about injection safety, it's about transfusion risks, it's about antischistosomal therapy, of course, in the older age groups who received antischistosomal therapy long ago in the 50s, 60s, and 70s, and that's why the huge reservoir of disease is in those above the age of 50. As far as injection safety is concerned, this is a huge problem in Egypt. We consume at around 1 billion injections on a yearly basis. 8% of those are considered to be, by WHO standards, to be unsafe. So we have a huge number of injections that are considered to be unsafe. Even if a person uses his own injection twice, this is considered to be unsafe. And the average number of injections per person given is 6.8 compared to 2.88 globally. And the average number of needle stick injuries per healthcare provider per year is 4.9 compared to 1.2 globally. And we have a lot of informal injectors, even in pharmacies. So this is one of the huge problems. And we thought that if we're thinking about prevention, this is one of the strategies that we should look into. Injection safety would be very important to prevent a lot of the infections ongoing in Egypt. So what about the developments between 2011 and 2014? First of all, on the prevention front, we sought the advice of WHO, US CDC, and Pasteur Institute to help us in establishment of an action plan that has all the components of prevention as well as screening, care, and treatment. That was in 2011, and there was a technical advisory group for WHO. And the action plan was launched in October 2014. And the best thing about this plan is it was multi-sectoral. All the sectors of health in Egypt, which is completely fragmented, Ministry of Health and Ministry of Higher Education, Ministry of Defense, amongst others, and the private sector, and each have their own jurisdiction. There is no national health committee that controls all the healthcare sectors. But for the first time, we had all the healthcare sectors on board, developing this plan, so to ensure that all of them will implement them in their sectors. It had all the components of surveillance, infection control, blood safety, vaccination, information, education, communication, as well as screening, care, and treatment. We started clinical trials with the new DAAs for genotype 4, and we started our negotiations and registered Sofosbuvir in 2014 at 1% of its US price, the first country to have the access program price. Gilead had a 3-tier price program, one for high-income countries, and one for middle-income, and one for low-income countries. Egypt, as I presented earlier, is a middle-income country. So we negotiated the price of the low-income countries because of the volume and because of the very good and well-developed infrastructure in Egypt that we had for treatment. So we initiated a web-based national enrollment web for registration for DAA treatment, and currently we have more than 1.2 million people registered on the web to receive treatment. The first patient who started this treatment was on 16th October 2014, and other DAAs, actually all of them that are registered now in Egypt and were available and introduced in 2015. If we look at other access programs, Georgia maybe has benefited also from the access program. They have a prevalence rate of Hep C of 7%. They're considered to be also a low middle income country. And they have also a partnership program with US CDC, their Ministry of Health, as well as the WHO and Gilead Sciences. And they're pledging to treat 20,000 people for free in Georgia, and they're getting technical support and guidance from the international organizations. But this is, of course, a very small number compared to Egypt. We've expanded our treatment centers during the past year to 47 treatment centers, covering all the governorates in Egypt except the frontier governorates where the prevalence rates are very low. And as we can see, maybe this is a bit too small, but the centers are distributed mainly in the Delta region. We have the largest numbers of centers in the Delta region because we had the largest burden of disease in the Delta region. Those were the people who received the parenteral anti-lysosomal therapy early on and have the highest burden of disease. So this is the chronology of the treatment protocols that we've implemented through our national programs. October 2014 through May 2015, we used soft PEG RIBA for F3s, F4s, interferon-tolerant patients, and we used soft RIBA for the interferon-intolerant patients down to child B7 for 24 weeks. Initially, of course, we were treating F1s to F3s only with the PEG, interferon, and RIBA, and we've treated those 350,000. May 2015, we introduced also the semi-Prevare. So we had the two protocols of soft PEG RIBA, still for the interferon tolerant, but we also included the F0s through F4s. We opened up for everybody. We initially prioritized the F3s and F4s, but by that time, by May, most of the waiting list for the F3s, F4s was finished. So we included also F0s. Everybody who was registered was included within the program. We were giving soft SIM for those interferon intolerant, but down to child A6 only, because as you know, there was a warning about the decompensated liver disease patients. November 2015, we introduced other DAAs, including the Ctrs. We introduced the 2D drug of AbbVie, only for renal disease, supported by the government, and the soft lead is being introduced currently, and we're waiting for the companies to produce the soft lead under the voluntary licensing. And we're treating also F0s to F4s, and the government program now has mainly soft DAC. This is the flow chart for enrollment of patients. Patients have to register on our web portal. This is our web portal. And then they have an appointment. It used to be an appointment within 3 months' time. Now it's 24 hours. There is no waiting list anymore. People get an appointment within 24 hours. They have to print out a page with a special number and the blood tests that he has to come with during his evaluation. He comes with the blood tests and abdominal ultrasound. He's being evaluated in the clinic and then enrolled. Data is being entered into the networking system. Each center has its own network that's connected to central office. And then after that, there is management review, which is both medical and administrative review, that this patient is eligible for government support. And then they get the approval for treatment fully endorsed by the government, as well as the lab tests. And the patients start their treatment, and the follow-up data is also downloaded on the system. This is how the registration system looks like. On the top left part, the patient has to write his national ID, his name, his mother's first name, residence, mobile number, and then a special code that's written. And once he does that, within 24 hours, he prints out a page with his scheduled appointment. The registry data for the first 4 days of registration, 250,000 patients registered on the web in the first 4 days only. And currently we have 1.2 more than 1.2 million now registered. 78.5% of those were naive, and 88% are supported by the government. The rest are supported by either national insurance or their insurance companies. Almost 66% are males and the rest are females, and the majority are between the age of 51 to 60, and the rest are distributed amongst other age groups. So if we look at the prices globally of sofosbuvir initially for 12 weeks of treatment per patient in US dollars, Egypt would have the lowest price, and we even have, Mongolia had a similar price later. India, maybe this is more for the generics, but Egypt now has the lowest price globally because we have our price in Egyptian pounds, so with the devaluation, unfortunately, of the Egyptian pound, the price is even lower. Those are the prices that were hypothesized for the price of the raw material by Andrew Hill in his very famous study for sofosbuvir, cimiprovir, and aclatasvir. And in fact, with the generics now in Egypt, we have 17 generic companies producing sofosbuvir, and we have 4 of them under license, and we have 4 companies under license to produce the soft-lead. We have 2 companies producing generic DAC. Unfortunately, we did not get the voluntary licensing out of 112 countries given the license by BMS. However, the price of the generic now in Egypt is as low as this. We have the generic bottle of sofosbuvir is less than $80, and the aclatasvir is less than $15 per bottle. So that's the course. That's the price of the course is less than $100 per month, so less than $300 per course of treatment, soft DAC. Those are the countries who've received the voluntary licensing to manufacture the sofosbuvir and the generic drugs, and most of them are in India, and they can export to 101 countries. Egypt has 2, and I think Pakistan has 1. BMS has given voluntary licensing to 112 countries. So if we look at the drug prices, Egypt has the lowest prices and has all the prices, and we've treated almost 200,000 patients during 2015, almost half of the numbers treated globally during 2015. And with our aggressive strategy, we're expecting to bring down the prevalence to less than 300,000 or even 300,000 by 2030. And cirrhosis, although it's going to be the biggest chunk by 2030, it will be around 39% of all the cases. However, the numbers will decrease dramatically by 2030. We're scaling up the continuum of care, and we've scaled up the numbers of treatment centers. We're updating our guidelines. We're increasing the number. We're now supported by WHO for our injection safety program, including the tech transfer for the new safety engineered devices. And these are going to make a huge shift in the prevention program. We're hugely supported by the media, tens of articles on monthly and on weekly basis. And we made the front line in the New York Times last mid-December by our program, and I think that was a great achievement for Egypt. It's good to know that the economic burden of disease, the direct health cost is around $670 million, and the indirect is $7.7 billion. If we cure patients, we'd save $10,000 per patient for the next 15 years. Preventing a case would save $20,000 for the next 40 years. And prevention and active cure would save us 1 million people more infected. And we're expecting to bring down the prevalence using cure as prevention and prevention as prevention by 2030 to less than 1%. We are having a lot of activities now for access of diagnosis and prevention and screening programs and undergraduate courses, but there remains to be a lot of challenges with the generics and quality assurance and voluntary licensing, pre-qualification, lack of legislation screening. We need point-of-care testing. We need access in remote areas. We need to treat children as soon as possible. And, of course, the stigma, adults and children. And I think I don't have enough time, but maybe I would go back to this one. This is the stepwise solution for the low middle income countries. We need data and situation analysis. We need to strengthen surveillance. We need to empower all those partners, including politicians and NGOs, government advocacy, development of national strategies to improve access. And I think the key word is access to prevention, diagnosis, as well as care and treatment. And this is my acknowledgement to all my colleagues in the National Committee and the Technical Advisory Group. Thank you.
Thank you very much, Dr. El Said. With unbelievable speed. If you cure Hep C as quickly as your presentation is, there won't be a problem tomorrow. We have time for a couple of questions at least. I'm sure there is some interest in this fascinating case studies. Who is up for questions, please?
Okay, so you talked about prevention. So what about prevention after treatment? We've learned about reinfection this morning. So is there a way to follow this? Can you evaluate it? Are there any measures? Are these people really, when they get treated, they're not reinfected?
One of the things that we're doing, we're thinking about reinfection, of course, all the time, because if the source is there, we give them the right advice, and we ask for family screening now on a regular basis. We started with family screening because we think that sometimes the transmission might be familial, especially in big families living in the same house with grandparents who are mostly infected because they are above the age of 50 and 55. So we're trying to give the right advice, but this needs also very vigilant monitoring, and this is something that we're working on. It's going to take a long time.
I just want to add something, you know, somebody tweeted in the room, so I have to find it. It says, Egypt 1, Mongolia 1, Canada 0.
Terrific talk, thank you. As a pediatrician, could you talk a little bit about the situation regarding children with hepatitis C in Egypt?
Yeah, in fact, in our last survey, we had lots of studies looking at 1 to 2% of children below the age of 15 who were infected with hepatitis C. But the last demographic health survey included also pediatrics from 0 to 15, and they came out with a prevalence rate of 0.3 to 0.5%. We're still having perinatal transmissions. At least 10,000 are added to the pool on a yearly basis. We have a special program for children through our NGO, and we recruited 1,000 children in a very short period of time. I'm also treating a huge cohort of children undergoing chemotherapy and multi-transfused, and the prevalence rate is above 70%. So we have a very, very high prevalence in the high-risk population groups. And unless we start treatment promptly and start and eradicate the virus in children, we're going to be faced with a very bad outcome in the next 10 years. I do have children with perinatal transmission with decompensated liver disease who need a liver transplant. We've transplanted a girl at the age of 14 with perinatal Hep C. And I have a child, 11 years, who needs a transplant, an urgent transplant right now, discovered by accident with decompensated liver disease. And I had many above the age of 15 whom I had to treat below 18 and exempt them from the treatment program because they had varices and they had advanced liver disease. So I think the pediatric group we should pay more attention to them. They represent 10% in this modeling study we've done with Center for Disease Analysis. It shows that they represent 10% of the global burden of hepatitis C. And unless we start to pay attention, I think hepatologists will be in business for a very long time.
Thank you again, Dr. El Said.